Dr. Puchalski, a professor of medicine at the George Washington University and the founding director of the Institute of Spirituality and Medicine at the George Washington University, is here with us today, and she's going to be the next speaker. She has also been doing some interesting work at the Vatican, and I would like to welcome her and listen to her speak rather than to me speak about her.
Thank you so much for that lovely introduction, and actually for the introduction to your organization this morning and last night. I'm deeply moved by the work that each of you do, and almost feel like saying, you know, I don't need to give a talk because you're already doing this. You're doing the most essential, which is to bring love to our patients. I'm going to talk very briefly about, and move through the slides fairly quickly, about my work, which started in the early 90s. And I recognized all along that we needed to integrate spirituality into healthcare, but I also recognized that people are dealing in systems where we see patients in small amounts of time, where everything is evidence-based by a certain criteria of clinically controlled trials. And spirituality to this date, although we're beginning to have more intervention studies, doesn't quite meet in that criteria. And it's difficult for a lot of people to grasp. I think everybody here, it's a good assumption on my part perhaps, but everybody here understands that, but not everybody else does. And my passion has been in trying to integrate spirituality so that everybody addresses it. People who are comfortable with it, who aren't. And so I'm going to briefly talk about some models that we've been involved in, as have others, to just show and I'm trying to figure out how to use this. I guess the forward is this way? Yeah, there, I think that's right, good. So no conflicts. So spirituality is whole person care, as we've heard. It transcends the control of disease process and relief of symptoms. It aims at full health. And I think that's the key issue here, that we're not just talking about physical health, but we're talking about finding healing authenticity even in the midst of end-of-life care, even in the midst of dying. My own clinical background, I'm an internist, primary care doctor by training, and then geriatrics and palliative care. So I do cross the whole spectrum. I do more palliative care these days, but I take care of patients of all ages. And so key to this work is the dignity of each person, regardless of their abilities or disabilities. Everybody has worth, and I've heard that so beautifully described by our first speaker and by the video as well. I want to bring your attention to the WHO. I've been doing some work with the World Health Organization, and their official definition of health in their constitution, which dates back to 1947, does not include the word spiritual. But this is a definition many people since 1947 have been trying to include spiritual well-being as part of the definition of health. And I will show you some work we did with the palliative care resolution where we finally got that word in. But the word spiritual is not that easy for a lot of people. I'm looking at a former dean here. I can tell you when I started a course on spirituality and health, there was a lot of concern from my dean about what is this? What's the motive behind this? What does it mean? Is it religion only? Is it New Age? What is this? I will just share that. It's not, in the general medical population, it's not always easily understood, and it's complex. So this is just a definition that has been proposed by people over the years. Now, one of my colleagues in Germany has done an international health congress, a consensus conference, to look at other definitions of health, recognizing that our population is aging. By 2020, the majority of people around the world, 2025, will be over 60, and by 2040, I think it is, the majority will be over 85 if we continue at our current rate. And so we know that people will be living longer, they already are, but perhaps with some challenges. So how do we define health for people like that? So she talks about the ability to adapt and self-manage, which I think is a beautiful definition. And if you look at the 3 bullets underneath in her consensus conference, she talked about this notion of dealing with chronic illness and to be healthy even in the presence of that, with the ability to perform relative to that condition, achieve individual fulfillment, meaning, and purpose. So that's the spirituality piece, achieving individual fulfillment, meaning, and purpose, all the way up until natural dying. And her focus groups, this is independent work of ours or anyone else, it's a completely different sector. She did a focus group with all of those different interdisciplinary professions and found the domains of physical, emotional, social, spiritual/existential, and others such as financial and intellectual. I was so fascinated when we co-presented at a meeting to see how much our work aligns with the work of palliative care. So the resolution that was passed, so now spirituality is officially in the Constitution in WHO, recognizes the whole person notion of palliative care. Palliative care is actually a good model of care in general. We define it as starting from the time of diagnosis of a serious illness all the way through recovery, perhaps there's recurrence, all the way through dying. And you can see, and I won't read each one of these, but the whole person model, spirituality is an essential domain. Second, it's the ethical responsibility of health systems. As I was watching that movie, Sai Baba recognized that. It's our ethical responsibility and that of health systems to be able to alleviate pain and suffering, whether it's physical, psychosocial, or spiritual. Really key. So when I heard the comment about listening to patients, and I'll allude to that a little bit later in my presentation, there's listening on many levels. There's listening to why they are here, but there's also knowing to listen to suffering. And listening to deep suffering is very difficult unless we're grounded in our own spirituality or our own way to be able to do that. I'll talk a little bit more about that at the workshop as well. And the networks between different professionals, so healthcare chaplains, board-certified chaplains are key members of the healthcare team, other types of spiritual counselors as well that are part of the healthcare team. WHO now recognizes that. So here's a definition. A lot of the work I've done has been through consensus conferences. That's another way of establishing evidence, if you will, or guidelines. And this was one that was done in Geneva. 42 countries were represented. It was diverse professions. And if you look at the definition, and I've already heard a little bit of that spirituality is more than religion, it's a dynamic and intrinsic aspect of humanity. Everybody is spiritual, through which persons seek ultimate meaning, purpose, and transcendence. An experienced relationship to self, family, others, community, society, nature, and the significant or sacred, however people understand that. And the researchers at this conference wanted something they could study, so we added the sentence, spirituality is expressed to beliefs, values, traditions, and practices. This is not a research definition, it's a framework for how we can listen to the spiritual stories of our patients. So ultimate meaning, the personal story I have on that is as a medical student, I rotated through a hospice, and I asked a spiritual history of one of my patients there, and she said she had never really thought about that. And now she's dying, and she never thought about her meaning. And so she said, this meaning that I have now, what is it? My family no longer, they preceded me in death. I can't work. All the things that gave me meaning, I don't have. What is that? So that's ultimate meaning, that meaning that will sustain us throughout our death and throughout our lives, both here and whatever we believe in afterlife. So that ultimate meaning is key in how people can come to face their illness. So Kathleen Dowling Singh wrote a beautiful book called Grace in Dying. And I think from my sense and understanding, is it's not just dying from an illness, but from the minute that we're born, we're dying in a sense. And she talks about dying as moving from chaos to surrender, a surrender not as in giving up, but a very beautiful surrender, a spiritual surrender that I know your Sai Baba had talked about as well, to eventual transcendence. So that initial encounter, we can be very chaotic with that initial encounter of our diagnosis. Surrender is that way of going into our deeper being. It's not, as I said, giving up. It's moving deeper within and being able to live with whatever life offers us. Transcendence is going deeper into spiritual integration. So this notion of how can we integrate our spirituality with our lives is really important. Okay, I think this is my water. So what are some clinical triggers? If we want to make this more reductionistic, what are clinical triggers for spiritual growth? All of those things. Aging, gerotranscendence is a beautiful area of research on the final stages of life, not so much aging, but as we're approaching death. serious illness, loss of a loved one, stress, life change, social events, tragedies, the why me question. All of these things can trigger for people a spiritual growth. So we as physicians, nurses, and others, we are sitting there breaking bad news or talking to our patient about what's going on with them, and they have a lot of spiritual issues going on inside of them, but we're not offering space for that conversation because we're focused on the symptoms, the 7 dimensions of that symptom, how we're going to treat that presenting symptom. But this may be the major thing going on for that patient at that time. Again, no time to go into this, but there is evidence. This isn't totally without evidence. A lot of it is association studies that show that people that are spiritual and or religious tend to live longer, tend to cope better, have less depression and anxiety, have better quality of life. There's a lot of surveys that show that the majority of patients want us to address their spirituality with them, and I'll talk about that more in the workshop on a tool of how to do a spiritual history. There's other types of, there's interventions that have actually been studied, meaning-oriented therapy. Bill Breitbart is a wonderful 8-session therapy, a psychotherapy for people with serious illness. Dignity therapy, Harvey Chachnoff from Canada has developed that as a beautiful way of approaching a patient, particularly at the end of life. Board-certified chaplains, there's huge amounts of research here and in Europe. I'm on the board of the European Research Institute for Chaplains in Healthcare Research. There's Transforming Chaplaincy. I'm also an advisor on that, where chaplains are beginning to do research, and they understand the dimension of spirituality. So many good studies coming out of that. Betty Farrell, my colleague, dear friend, and mentor at City of Hope here in LA, actually nearby here, has done an intervention looking at an education intervention for patients with cancer and their families. And the experimental group had a spiritual education module taught by the chaplain and other members of the team. The experimental had an enhanced social intervention. The experimental group had less depression, less anxiety, better quality of life. And all of us are scored, by the way, and better patient experience. All of us are scored on patient experience, quality of life of our patients. Without addressing spirituality, we can't really begin to approach a patient's quality of life. In Europe, there's a study looking at spiritual care outcome measures where they interviewed patients who were seen by healthcare chaplains there, and there were many positive outcomes, qualitative studies. They're now doing quantitative studies with this, where people who've received professional spiritual care had felt listened to. We heard about listening, felt really listened to, a sense of peace, an increased sense of hope and control. We did a project, Betty Farrell and I, here actually in Southern California, which ended up in a book called Making Healthcare Whole, building on the already required domain of spiritual, religious, and existential aspects within palliative care, again, broadly defined. And this was strategic. While I talk about this in all of care, palliative care is a field that already has this as one of its requirements. Including we're doing work on the Hill, where we're trying, at the Capitol, to try to, not so much in this administration, but last administration, there was a lot of input, I'm sorry to say that, but there was a lot of interest in this more whole person care. We're still up there, but it's a little challenging right now. Interprofessional spiritual care, so what is the summary of that model, that whole person model? It's integral to any patient-centered health system based on honoring dignity, attending to suffering. Spiritual distress is treated like any other medical problem. So in the meeting, what they said is, every patient is asked what is their pain on a scale of 1 to 10. How many people ask about spiritual, emotional, or social distress? None. So it's really key that we look at spirituality. Yes, it's an integral part of health, but spiritual distress can actually be the predominant distress symptom of that patient. So we need to diagnose that. Reductionistic, but I think very, very important. And I talked about some of the other aspects. Not going to go through this. Happy to share these slides and paper with you. Just to say, we worked very hard on a model about where the patient gets a spiritual screening, history, or assessment. Screening at the beginning, history, those of us who develop care plans or treatment plans, assessment by the board-certified chaplain or the professional spiritual care provider. Parenthetically, I am doing some work now in different parts of the world, and I have some colleagues in India as well, on how do we develop professional spiritual care providers in different parts of the world that don't have chaplains. What you heard about earlier is the personal and professional development. Also, we'll talk about that later, but we need our own professional development to be able to interact with our patients, to enter that dotted line, transformational interaction, to be truly present to suffering. And it's all of our responsibilities on the team to listen to all of the patient's issues, all of them. So everybody, you may have a chaplain on the team, but the doctors, nurses, social workers, and others also need to be aware of that domain and others. So all of us in this room, I love making diagnoses. I love getting complicated patient referrals. I think it's incredibly challenging. And this is basically the path here. Is this person, what's going on with this person? What are their resources of strength, physical, emotional, social, spiritual? If they're in distress, where is that distress coming from? And who else on the team should be involved? So, and thank you to Geetha, my former student, for introducing me to this wonderful group. She is, and many of us are in stress systems where we're seeing patients maybe every 10 minutes. So we may not be able to do something in depth. Who else is on the team we can work with? These are the spiritual distress diagnoses that came from the NCCN guidelines, comprehensive guidelines, National Cancer Center guidelines, and comprehensive center guidelines. We also added a few for our consensus conference. So as you can see, it's many things. It's not just about religious. It's about other types of issues too. Isolation, loneliness, grief, despair, concerns about relationship with the deity or transcendent, however people see that. And I see this a lot in my practice. So what can we do? You're probably saying, okay, many people say this to me. So what if I diagnose one of those spiritual distress diagnoses? What do? Compassionate presence. And that's more than being compassionate. It's more than being sympathetic. Presence is really a spiritual act. It's a sacred act. We do a retreat every year in Assisi, Italy, called The Art of Presence, where we delve into this a little deeper. It's really a sacred act. So I'm just going to share a patient of mine. This happened around 9/11. I was, obviously, you know, the Pentagon was hit. I'm at GW. We were asked to stay to help if any of the victims were going to come from Pentagon to GW. I ended up covering for the palliative care unit while some of them were doing the ER and other things. And this was a patient, 46, metastatic cancer, married, 2 children, wanted to live to see them graduate. And now it looked like that wasn't going to happen. Also, her friends were in that part of the building that she used to work there that were hit, so her friends died. And so she was filled with a lot of issues. And among her issues was her awareness of her own dying and that was approaching. She felt despair. She felt God wasn't there for her. Her own mother died of breast cancer, and she was nervous about how she was going to bring suffering upon her children. So the FICA tool, which is a spiritual history tool, of course I did a complete assessment. Part of the social history was this. And so she's Catholic, meaning is family, God, and she talked about Mary a lot. This is a woman model for her, and she saw her as a model for being a mother who suffered as Mary watched her son be killed. Very important in her life, but God she feels he kind of let her down. She doesn't really want aggressive care. We talked about goals of care, but she doesn't want last rites, which is a healing practice within the Catholic Church. She didn't want that. So I sense that there was some conflict with her community, which she said now she's awkward about their visits. She maybe would like someone to do that last rites, but not sure about the priest from her church. So a lot of issues that were there for her. Of course, I did a good review of systems. Now, this is not just about spirituality, but I looked at the distress as well, which here was some anger at God, a fear of uncertainty, existential distress, and despair. So this is what we teach at GW now. We actually teach this in many different sections, from the moment of orientation all the way through how to write an assessment and treatment plan in the electronic health record that includes all of those domains. So this is what it would look like for this patient. A brief summary of who she is, what are her physical issues, what we would continue doing for her emotionally, the family meeting, and then spiritual referral to a chaplain, coordinate a visit with a priest for sacraments, should she desire that, and my continued or the team continued presence. And so this is the idea of bringing spirituality in so that even people who aren't physicians and others who aren't maybe that aware of spirituality in their own lives at least learn how to listen to it in their patients' lives. So I now want to move into what we talk a lot about, which is attending to suffering. What does that mean to attend? It's an accompaniment. It's an accompaniment with our patients through whatever suffering they're going through. It's to be present, to support, to commit to listen, and to be there for the patient. And it is a part of our call, part of our vocation. Pope Francis, in his encyclical, which everyone thought it was about the earth, but he included people in that. Of course, we're part of that. He said all of our jobs should be more than just a job. We are born to a call, and we need to work out of that call. And that is what a lot of the work in our medical education now is moving through at GW and other places. How do we help our students get in touch with their call? And more importantly, how do we keep that alive in them and in all of our work? So to attend to suffering in isolation, this is from the internet, but it reminded me of when I was a third-year medical student. I went on the wards. One day, my patient who was next to the nurse's station was all the way down and in an isolated room. And that's what she looked like, though she was lying in bed, because she was dying and there was, quote, no more that we could do for her. And I just held her hand and she cried and I listened. I'm not sure that there were many words exchanged. How do we not turn ourselves away from the suffering around the world? And Mother Teresa talks about how much suffering there is over the entire world, as I know your leader has as well. There is data on this. My colleague Shane Sinclair is a chaplain who's he's developing an empirical model in compassion and health. And from his interviews with patients about what they consider compassionate, what you can see there is there's themes. There's virtue, our love. Love, I mean, bringing love to our patients, relational space, that we're engaged with them, that they're the priority, our virtuous response. Even though people in the hallway are saying, Dr. Puchalski, you're an hour behind, when I go into that room, they are number one. And that's a challenge, but that's important. Seeking to understand, a basic curiosity. How do we understand our patients? How do we learn more about them? That takes time too. Our demeanor, and then attending to all those needs, including the spiritual. So witnessing to suffering means giving voice to the person who is suffering. Any of you that may have suffered in your lives, we know it's hard to put words on it. And people want to kind of make us move through that uncomfortable feeling. It's uncomfortable for them. But that's not the best in the best interest of the patient. We need to be silent and let them just talk, cry, reach out to us. My friend and an Episcopal priest who died last year, she was also my patient and she was on our board. I knew her in many different ways. She says, you don't really know who this human being is, the full depth of the person, the soul. You don't really know who that person is, and so you listen. It's listening to their soul. It's listening. And that you can't do with a reductionistic model. Henry Nouwen has written, listening is much more than allowing another to talk while waiting for a chance to respond. Listening is paying full attention to others and welcoming them into our very beings. The beauty of listening is that those who are listened to start feeling accepted, start taking their words more seriously, and discovering their true selves. Listening is a form of spiritual hospitality by which you invite strangers to be friends, to get to know their inner selves more fully, and even to dare to be silent with you. So that reductionistic model, I snuck those dotted lines in. And what did I call that? What did we all call that in that meeting? Spiritual transformation. We are transformed spiritually by, and in many other ways, by our encounter with patients as they are with us. So if I go in and I'm on the computer saying, okay, oh, I see you're here for blood pressure, I see you're here, right? Okay, well, that's not a relationship, right? We really need to recognize the holiness of this work. So we developed a model with the Fetzer Institute showing how our spirituality, our own spirituality, and there's much research being done on this now, but how our spirituality can lead to our capacity to be a presence, to show compassion. And Viz, who gave me a ride yesterday, shared his experiences with Swami, and I know that you have that within your belief, within his teachings. How do we bring that part of ourselves to love, to show compassion? Compassion asks us to go where it hurts, to enter into places of pain, to share in brokenness, confusion. Think of that, all that. And that's so difficult to do, to cry out with those in misery. Compassion means full immersion into the condition of being human. So I want to share a story about my father. This is my dad. And at that time, this was 3 years ago. So he's 96 now, so he was almost 94 at that time. He was 93. And he had an incisional hernia that was, we were just hoping that we would never have to operate, but we did. It was very big, was no longer reducible, and loss of domain was a key concern, which is a very painful death. So Dr. Lee, Juliet Lee, general surgeon at GW, was operating on him. And the usual pre-op stuff was going on in the room. Okay, you know that you could die from the anesthesia, da-da-da-da-da-da-da. So I said, first of all, he can't hear. Second of all, I'm his DPOA. I'll sign the consent. Just take this energy out, but this was going on. So my dad turns to me and he said, Chrissy, take me home. Well, in that moment, I just flashed to what, I'd never be able to do that colon prep with him. He'd never come back. He would die. And I was so sad. I was so scared. So Dr. Lee just, told everybody to go away. She pulled the curtains, and she simply listened. Mr. Puchalski, what's going on? So he told her and was like, so high energy, and she knows his spirituality, and part of it is being an opera singer. So when he finally calmed down, and she was able to read that moment, she said, Mr. Puchalski, would you sing for me? So he sang O Sole Mio, very loudly. And then he turned to me, he goes, I'm ready now. Now, the next part of that story is in the ICU. I find out that she's a trained soprano. So the incentive spirometer did nothing for him. He's got, opera singer lungs. So they would sing arias back and forth to each other in the ICU. That's what I'm talking about, witnessing to suffering. She did not say a word. She did not say a word when she interacted with my dad in that moment. She just let him talk and saved his life. So compassionate care is that clinical dance of science and spirituality. We do need to do that assessment and the record keeping and all, but we also need that deep listening, and that's what's so key about this. We all, whether we're clergy, I presented this at the Vatican, we all find it easier to focus on the technical. It's much easier for us to deal at that level. It's much harder to deal with suffering. It's much harder to deal with that inner part. But people want us. It's the number one need in hospitals is to have love and belonging. So this comes from a friend of mine, Art Lucas, chaplain leader, who died of pancreatic cancer about 6 months after we left. We met, and I asked him if I could use this slide. I like to honor him. I learned so much from him. This is what presence is, sitting in the center with another as the caregiver and patient meet, as one hunkers down, is fully present with another. So our stories become one. And I already mentioned this from the Pope. I want to just end with a global network for spirituality and health that grew out of a lot of this work. And there are people from all over the world. We now have 465 members. We would love to just highlight your work because this network is about facilitating conversations, highlighting work. We're on Sathya, which is an online thing where people publish, people share stories, that comes out. So it's we've built this model based on the Consensus Conference. A lot of our work, so what the Global Network did is they worked with the WHO through myself and others to develop guidelines on spiritual care within palliative care, and that we have a chapter on that in a book, Building Integrated Palliative Care Services, edited by Stephen Connor and Xavier Gomez Baptiste. And they're examples of spiritual care stories from around the world. So I quoted Mother Teresa before, but care of the person is based on honoring dignity, attending to suffering. We can cure physical diseases with medicine, but the only cure for loneliness, despair, and hopelessness is love. There are many people in the world who are dying for a piece of bread, but there are many more dying for a little love. Thank you so much for your work, and thank you so much for your attention this morning.